Okay.
Thank you. Thank you, Rachel, and thanks everybody for being here. This is the second part to Dr. Dellinger's talk that he gave 2 weeks ago, and this is a topic that we've spoken about on this platform multiple times, and that's not a mistake because it's such an important topic. It contributes significantly to maternal morbidity and mortality, one of the leading causes for death in our maternal population. Um, our learning objectives are listed here. I'll just go through them quickly so that you get why I think that it's so important and what we're going to focus on today. I want everybody to understand the importance of assessing risk factors uh, that helps us decide whether a patient needs medical prophylaxis with low molecular weight heparin in their pregnancy or not. Look at different schemes of VTE prophylaxis and understand how weight may alter recommendations for the different doses that we use. So do this a little bit differently. I'm going to start out with a case, and then at the end, we'll take a break, answer questions, and then we'll go back to the case. So the case that we're going to discuss later is a 41-year-old G2P1, 8 weeks gestational age. Her BMI is 59. She's 346 pounds. She has a history of a pulmonary embolus in her last pregnancy, which was a few years ago. And that pulmonary embolus occurred at 14 weeks gestation. She had severe shortness of breath, chest pain, came to the ER and was diagnosed and started on blood thinners. Her workup trying to find a potential cause for her clot was negative. She didn't have any of the thrombophilias we test for, and her lupus labs were normal. She was treated with Lovenox or low molecular weight heparin, a therapeutic dose for the pregnancy and through 6 weeks postpartum, 1 milligram per kg twice a day. And because her workup was negative, it was stopped at 6 weeks and she didn't require any more. Family history is significant in that her mother passed away from a pulmonary embolus at age 52 that was not precipitated by anything that could be determined. So, what I'd like to do as we go through the case or through the presentation, kind of keep this case in mind and think about what type of dosing of medicinal prophylaxis or therapeutic low molecular weight heparin you would consider using for this patient or suggesting to this patient in her pregnancy. So, we have a lot of stakeholders that attend these project echoes, and I think that's so important. And this is a perfect example, and we'll talk about that particularly in the end. Uh, you may be with insurance companies, you may be community health workers, doulas, whatever role you play in your interaction with pregnant patients. It's important to have some understanding of venous thromboembolism and the risk in pregnancy. So to understand kind of where we're going with this topic, what exactly is prophylaxis? Well, it's something that we use to help prevent a certain problem. An example is if a patient has herpes virus that we give Valtrex or Valcyclovir toward the end of pregnancy to prevent third trimester shedding of the virus and prevent neonatal infection. In this particular topic, we give a blood thinner to help prevent a clot from happening in certain patients. So, who should receive prophylaxis? Well, it's the patients at highest risk of having the problem, right? So, in those patients that we're considering Valtrex, for instance, we would give that to patients who have a history of genital herpes. For those with the need for VTE prophylaxis, we're going to talk about giving that or considering that medication in patients who are at the highest risk of having a blood clot. That can be whether they've had a history of a blood clot, a clotting disorder, or a family with a history of having blood clots, either to do with pregnancy or not. So, risk factor assessment is really important when we're talking about how to decide whether to give a patient VTE prophylaxis, and it needs to be a progressive risk factor assessment. In reality, most patients come to see us after they're already pregnant. We would love to focus this on pre-pregnancy counseling as well, but we're going to really today talk about during pregnancy. So we want to assess for risk factors early in pregnancy, as soon as they come in to see us in the office, when they're admitted to the hospital for delivery, or if they're admitted to the hospital for any other situation in their pregnancy. And then if they have a pregnancy complication occur, assess that's association with any increased risk of clots. And I think one of the things that we have not focused enough in the healthcare community is remember our patients community, family education, and get involvement with everybody in the community to help us spread the word of what the risk for thromboembolism is and how it might affect a pregnancy. So risk factors for blood clots, Dr. Dellinger went through these last week. Just to mention them again, pregnancy increases the risk of clots by 6 to 9 times, but look at that postpartum risk, 60 to 80 times higher. Thrombophilias, that is either inherited or acquired conditions that are associated with an increased risk of developing clots. We know that obesity increases the risk, having a cesarean section or other surgeries. And then if a patient has other comorbidities like diabetes, hypertension, if they smoke, any of those things can be associated with an increased risk. So risk stratification is really important. So I'm not going to go into this in a lot of detail, but prior VTE is the most important risk factor, or one of the most important. Women who have had a clot either in their leg or to their lungs, or if they've had recurrent clots, they should be automatically thought of as candidates for antepartum, that is before delivery, and or postpartum prophylaxis with low molecular weight heparin. Now, there are patients who have non-recurring risk factors. For instance, if Jane Doe had a clot that developed in her leg that went to her lung after she had a fracture of her ankle, that's called a provoked venothromboembolism, and the recurrence risk is really not very high. They may or may not be a candidate for use of low molecular weight heparin, particularly postpartum, if there are other risk factors present with that patient. So it doesn't automatically mean that patient doesn't need prophylaxis, but you need to look at the whole history. High risk thrombophilias are listed here. Again, we went through these last session, and I think that it's pretty clear that pharmacological prophylaxis with low molecular weight heparin is recommended anytime one of these is present, regardless of whether there are other risk factors that are present with the patient. Low risk thrombophilias are a little bit more confusing, and we'll kind of walk through a lot of the recommendations for this. prophylaxis decisions with low risk thrombophilias, really we individualize whether to treat or not based on presence of other risk factors. Is there a family history of a clot? Are they obese? Are they going to have a cesarean section for delivery? Do they have heart conditions, prolonged immobility? And really best to involve, even if it's a phone call, to your MFM or hematologist to help make that decision. Before I go any further, I think it's important to understand that, and I really should have done this early on, I always forget, and that is prophylaxis is not just pharmacologic. There is mechanical prophylaxis for clots that definitely decreases the risk of venothromboembolism in pregnancy if a patient is immobilized. For instance, the pneumatic compression devices that we use in the hospital definitely decrease the risk. There's a lot of debate on whether compression hose help, position changes help, but activity definitely helps. We're going to focus today mainly on medicinal prophylaxis. Not going to talk really about unfractionated heparin. I'm happy to answer questions about it, but we've really rolled into using low molecular weight heparin, inoxapril or Lovenox, the one that we choose here in the United States most often. So the different regimens, I'm going to go through just briefly looking at different organizations that have recommendations. This is from ACOG's Practice Bulletin. The most recent one on this topic was back in 2018. And it basically goes through three different regimens. The first is just the basic low dose prophylactic low molecular weight heparin. Enoxaparin is Lovenox, and they use as their prophylactic dose 40 milligrams a day, once a day, across the board, no matter what the patient's size is. Intermediate dose is increasing that dose to twice a day, and I'll go into why you would do an intermediate dose versus just a daily dose. And then adjusted dose is where you're giving the patient a therapeutic dose of Lovenox, which fully thins their blood. It is associated with the lowest risk of thromboembolism recurrence in a patient. I used to love this, and I still like it better than ACOG recommendations on prophylactic Lovenox, and it's weight-based use of Lovenox as proposed by the Royal College of OBGYN in Great Britain. This is also very similar to the American College of Surgeons and Cardiothoracic Surgeons that they use. It's weight-based, and that matters because patients who are larger require a higher dose to have an effective prophylactic effect to help prevent a clot. So this requires you to have, I used to have this, I actually still do, even though I don't use it anymore. I have this chart next to my desk on the wall. I would frequently refer to it to help me decide what dose of Lovenox to place a patient on. And the majority of our patients fell into that 90 to 130 or 131 to 170 category. So I automatically went to that 60 to 80 milligrams per day. But this is still a very acceptable way to prophylax women, to calculate a dose of prophylaxis that I think is better than the ACOG recommendations. Next. And then this is where we have landed in our division here at Prisma Midlands, and it really came about after a lot of discussion with all our partners. And there are actually good papers that substantiate this as a very effective way to prophylax women that are pregnant from VTE. And it's just simply using one dose for everybody, to calculate one dose for everybody, using 1 milligram per kg once a day up to 100 kgs. And if they go over 100 kgs, we stop at 100 milligrams of Lovenox for the day. So, how do we decide which dose regimen to use? I think it's really important to use informed decision making to discuss it with patients. The thing that we like about the 1 milligram per kg is it's pretty straightforward, it's simple, and there's no variation. And we're all doing the same thing. And it is very effective. Remember that the higher dose of prophylactic medication we use, the lower the risk of a blood clot. Now, you also have to remember that the higher the dose, there's a higher risk of bleeding complications, bruising, bleeding from the gums, even the possibility of subchorionic hemorrhage. But those risks are small, and if they do occur, you can lower the dose. You just have to weigh the benefits and risks, look at the patient's risk factors, and let that patient help make the decision with you. One of the most important things, if you're talking about adherence to a care plan, is trying to make it as easy as you can for the patient. And that is a single injection a day. No doubt that the best pharmacokinetics occur if you split the dose. If I took 1 milligram per kg and split it in 2 times a day, that's probably more effective than a single injection a day, but it decreases the patient adherence to that care plan. The other thing that helps enhance adherence is to talk about the side effects and ways to lessen the side effects. For instance, one of the biggest things that patients complain about with Lovenox use is the burning, the stinging, because it hurts to give the injection, and the bruising. And one of the things that I've found tremendously helpful in these patients is to use a piece of ice on the injection site 30 seconds, 20, 30, 40 seconds before they do the injection. And what that does is it not only numbs the skin, but it also causes vasoconstriction of the surface vessels, and they don't get nearly as much bruising, and they tolerate it better. So trying to come up with ways to help them have fewer side effects will enhance them using the medications they should. These are busy slides. They will be here for your reference, but I think they're very important. These are the slides from ACOG that I do find helpful. I was actually on the committee that helped write the first practice bulletin that had the first iteration of this. And I have to tell you, it is not set in stone. It gives you different options for different situations so that it's not one solution for every patient, but it at least gives you guidelines. This is another one of those pages that I have on my wall in my office because it does help me as I'm trying to decide what to recommend to a patient or what to offer her. And frequently, I'll go over all of the options. The very first clinical scenario here is history of single unprovoked blood clot with no precipitating factor. It includes those who have a clot in pregnancy or associated with contraception, and they're not on long-term anticoagulation. So during their antepartum period, this bulletin says you can do anything you want. You can give prophylactic Lovenox. You can give that intermediate dose that we're talking about that we use here, or you can do full anticoagulation. and discuss with the patient. The higher the dose, the lower the risk of a clot, but the higher the dose, the higher the risk of complications. And those can help with making the decision for that patient. Some patients will go with the full anticoagulation, even though I think they only need prophylactic. But that's very important to include them in making that decision. Now, postpartum, in this particular situation, they give you the same recommendations, but many times postpartum, we will go up to the next level. If we were using the low dose prophylaxis during pregnancy, we'll go up to the intermediate dose postpartum because that's the time that the risk is highest. And we do that for 6 weeks. I'll stop with that, go to the next one. And this is another series of clinical scenarios with low risk thrombophilias with a previous blood clot, at least one clot. Again, it doesn't recommend full anticoagulation, but does recommend either low dose prophylaxis or intermediate dose. And then postpartum, the same, or you can go up to the higher dose. The high risk thrombophilias, everybody is recommended to have some form of prophylaxis. And then it gets more aggressive the more historical factors they have. And then this is just more of the same. I'm not going to go into all this. So, with a planned vaginal delivery or cesarean section, there is, when a patient is using low molecular weight heparin Lovenox, there is a risk of epidural hematoma if an epidural or regional anesthesia is utilized within 12 hours of the last dose. So with prophylactic doses of Lovenox, we recommend holding that dose 12 hours or more before regional anesthesia. So if they're coming in for labor induction, we hold that dose the day before. Therapeutic doses for 24 hours. And what we tell our patients is if you start having contractions at home or you're not sure whether you're going into labor and it's time for a dose of your Lovenox, just hold it. It's safer to hold that dose than it is to go ahead and take it, come in and desire regional anesthesia. Honestly, the actual risk of bleeding within those periods of time, like vaginal bleeding with a delivery or after delivery, is not significantly increased with the doses that we're talking about. The last thing I'll mention with this is that we don't switch to unfractionated heparin anymore at 36 weeks like we used to. We got used to using the Lovenox and just stopping it before delivery when we had a shortage of heparin. So we just continue them on Lovenox up until delivery. Rachel, we can stop here if you want to and give folks an opportunity to ask questions or give some input, and then we can finish up with this case and talk through